Now I will.
And the time is also correct. So we start, okay?
Okay. Thank
So
you all
just
for inviting me for this session. Hello, everyone. I'm Dr. Mahmoud Elsaidy. I hope you are doing well for the preparation for the exam. Nice to meet you all. I want only to remind you about the YouTube channel, RadMe Radiology, and there is Eagle Eye videos for the rapid reporting preparation. I feel it is very important for the preparation and it will help you very much. Also for the website RadMe Radiology, there is a free packets for the long and rapid reporting. It uses the same software of the exam. Also, it is a good chance to prepare for the exam through the same website. Let's start our session. We have candidate 1. Can you see my screen?
Yes, I can. Hi, Dr. Mahmoud.
We will start by candidate 1.
yeah, candidate 1,
Yes.
please.
Okay,
I'm muting
candidate 2. Okay.
Candidate 2, I'm muting.
Okay.
Dr. Marwa, I'm muting you. Candidate
Okay.
1 is Dr. Samir.
Okay, let's start. This is the first case. We have this patient with headache. Doctor, candidate 1, you can request the remote control. Yeah, approve. You can go up and down through the case. What is this sequence?
Okay, this is the T2 sequence, exit sequence.
Okay. What can you see here?
So I'm presented by axial MRI T2 scan of the brain for 50 years old female patient. What I can see from the first look is the dilatation of the lateral ventricle at both sides. So I will go through this image. I can see there's also small hyper intense foci seen at the left high frontal region, subcortical, going down.
This dilatation of the ventricles, is it acute or chronic? Is it related to acute process or related to a chronic volume loss?
I can see there is minimal permeation periventricular here. However, I will confirm in the FLAIR image if this periventricular CSF permeation is evident, so it is going with acute.
So what could be the cause for this?
I will go down to search for the cause of this obstruction. Here I can see this.
Can you tell me which ventricles are dilated?
The lateral ventricles here are the dilated ones, posterior and anterior horns. However, I couldn't
Only
see
the lateral?
The temporal horn I am searching for.
Only the lateral ventricles?
Yes, here I can see the lateral ventricles.
Anything else?
I am going to check for the fourth ventricle. I couldn't see it dilated. Going up again for the third ventricle. I couldn't see. There is mild dilatation of the third ventricle. I will think about any compressing lesion.
Like what?
Could be make mass effect on the.
Like what? Like what lesions?
Like tectal plate glioma, like pineal lesions.
What you will do next?
I will assess the other planes, sagittal plane, and to check for any lesions.
Okay, we have another patient. Yeah, he has cough.
Yeah, so I'm presented by frontal chest radiograph, skeletal immature patient. I can see from the first look there is obscuring the right cardiac border. So it is keeping with right middle loop consolidation.
What you will do
Collapse.
next?
I will ask about the clinical data of the patient if there is any constitutional symptoms, so it is likely of inflammatory process.
Hmm?
If no, I will think about collapse of the middle
What you
loop.
will
I
do
will
next?
CT with contrast,
And what will be the
search-
management?
searching for any obstructing lesion.
If there is no obstruction, what will be the management?
If no obstruction, so it's keeping with inflammatory process. I will transfer the findings to the referring physician for management and follow up for
What is the management?
after 4 to 6 weeks follow up X-ray to search if resolution. So no need for further
Okay,
management.
we have another patient here. This is a CT abdomen. Can you take the control again?
Yeah.
Yeah.
So this is CT abdomen for elderly male patient.
Mhm.
I'm scrolling down. Yes, this is the end of the study. So I will scroll up through this study. Yes, I can see there is evidence of hernia. There is soft tissue mass lesion seen in front of the left, the right inguinal region. This likely representing hernial sac. This hernial sac seen compressing the right femoral vein partially and extending down. So it is in keeping with the right femoral hernia. I will check for the bowel loops for any obstruction. Yes, here is the dilatation with gas locule seen at the wall of the bowel. So it is pneumatosis. Also, I will go up to the liver to check for any portal venous gas. I couldn't see any portal venous gas. In my routine practice, I will check this patient in the pulmonary or lung window, searching for any free air in the peritoneum, and also checking the contrast study for assessing the integrity of the bowel loops. As I couldn't assess the bowel loop integrity here, rather than the pneumatosis, no evidence of fluid collection
So in conclusion, what is happening here?
So my conclusion, this is there is obstructing strangulated right femoral hernia with bowel loop pneumatosis, no gas.
Is there bowel obstruction?
I cannot see any evident dilatation of the bowel loops. The gallbladder also I can see it is distended. So I am worried about
What will you do next?
the obstruction. I will assess in the contrast enhanced images and transfer these findings urgently for the surgical team for management of this strangulated femoral hernia as it is an emergency operation.
This patient has thigh pain.
So I'm presented by distal femoral radiograph of 13 years old patient. I can see there is evidence of large lesion affecting the distal part of the femur with periosteal reaction and infiltration, also vertical breach at both sides. So it is a wide zone of transition. This in such age group, I will put the differentials of aggressive bony lesions like osteosarcoma in the top of my differential.
What you will do next?
I will recommend the MRI study for this patient starting from the hip to the ankle, searching for any skipped lesions, and also assess the other side in the MRI study, the other limb, and CT chest, abdomen, and pelvis, searching for any metastatic lesions with bone scan, and transfer the patient for to be discussed at orthopedic oncology MDT for biopsy at tertiary sarcoma center.
Okay. This is your last case. Can you take the control?
Yeah. So this is a CT scan for a young child from the skull bone. It is less than 1 year, I think. I am still scrolling here. I can see there is evidence of hyper density seen at the posterior aspect at the level of internal cerebral veins and
The veins are okay.
inferior sagittal sinus.
The sinuses are okay.
I am scrolling still to search for any other abnormality. So this is the last image of the study. I will scroll up again to searching for abnormality in this scan. The orbit looks normal.
What is the
I can
hyperdensity
see
you
there is
mentioned before?
evidence of hyperdensity seen at the right side of the orbit.
I ignore it.
Yeah.
What is the hyperdensity you mentioned before? Where it is exactly?
This at the level of inferior sagittal sinus.
No, the sinuses are okay. What is the structure
And also
between the supratentorium and infratentorium?
the midbrain.
No, the hyperdensity, where it is? Is there any other abnormality other than the hyperdensity?
I can see there is evidence of hyperdense Elsaidy, and there is mild midline shifting to the
No
right side.
midline shift. Is there anything else?
The ventricles also, I can see it is compressed, and
Why it is compressed?
the lateral, frontal horn of lateral ventricle.
Yeah, why?
Largely compressed. So I'm worried about in such age group of subdural hematoma. However, I couldn't assess here, so I will
What else? What else other than the subdural hematoma?
I am searching also to check for any evidence of skull fractures. However, I will use a bone window to check for any
What you
skull
will do
fracture.
next?
As I am worried about non-accidental injury in such age group, I will assess by MRI study to confirm the findings of subdural.
What else?
And I will do a survey, X-ray scan. Also, I will call the child safety
We have the
authority.
skeletal survey. Is there any abnormality in this limb? No, don't change it. No, please. Yeah, don't change that.
Can I zoom it, please, this radiograph, as I couldn't see, I can't exactly. I'm worried here about
Don't
any,
move. Don't move the. Don't move
I
the mouse.
need to zoom if I can be, please.
What
As
you will
I'm
search for?
I'm searching for metaphyseal corner fractures here.
Okay, thank you. Thank you. Time is up. Thanks. Candidate 2? Candidate 2 is ready?
Yes, I'm ready. Hi, Dr.
Oh,
Mahmoud.
okay, hi. Let's start. Okay. You have the control?
Just 1 second.
Yeah, you can ask the to take the control. Approve.
Yes, I have now. Yeah.
Yeah, okay. Yeah, you can go up and down or by the mouse. I started the timer.
Okay. So I'm presented with the CT brain axial cuts. I'm scrolling through the cuts from above to below. I can see there is this is an contrast study. I can see there is a hyperdensity seen in the anterior falx, also at the sulci, and I can see also I'm searching for intraventricular hemorrhage. I cannot see clearly an intraventricular hemorrhage, but I can see dilated ventricles. So I'm suspicious of subarachnoid hemorrhage.
What could
For
be
this
the
patient,
cause?
the cause of subarachnoid hemorrhage is either traumatic, so I will ask.
In this case, what could be the cause?
I think it is, for this case, I think it is ruptured aneurysm.
Where it is?
1 second, because the scrolling is, I think it's ACOM aneurysm because there is a hyperdensity in the frontal lobes with surrounding edema. So I think it's ACOM or anterior cerebral artery aneurysm. It's ruptured aneurysm. Yes.
You mentioned surrounding edema?
Yes, I can see parafalcine hyperdensity.
What could be the cause of this?
It could be infarction, post rupture aneurysm infarction because of decreased blood flow to this area.
What make the blood flow decreased in this area?
Because of the vasospasm following the rupture of the aneurysm.
Any other causes?
No, I'm not sure of the cause, of the other cause.
Okay, thank
I think
you.
maybe.
No problem. We have another patient. This child X-ray.
Okay, I'm presented with the frontal X-ray of a premature of an infant. I think he's mature. No, not he's mature. Not preterm. Yani. I can see there is whitening out of the left hemithorax. I can see also there is rib fracture. So in this case, there is a fracture, lower rib fracture in this child. In this case, I would be concerned about if there is non-accidental injury with rib fractures and the hemothorax. So I would ask about the clinical history of the patient, alert local authorities, and also safeguard the other children. If he has siblings, and if he has neurological manifestations, I will be doing a CT if he is having
what could be
neurological
the
manifestations.
relevant medical history? You mentioned you will ask for the clinical history.
I would ask about if there is if they gave no history of trauma to the child,
Mhm.
but there is a fracture. So if the history is not
This is the skeletal
concordant.
survey.
Okay, I
Can you
can
see
see.
anything?
I think there is dislocation of the radius, maybe.
Dislocation?
Yeah, of the radial head. And there is also, there is also a fracture of the distal ulna and also the distal radius. There is buccal fracture of the distal radius and the ulna.
We have another images. Is there anything here?
Okay, I'm looking for skull fractures. I can see there is the breast fracture in the left parietal bone.
Okay, and here?
Okay. Here I'm looking for either a non-ambulatory fracture, spiral fracture, non-ambulatory child,
Is
or
there
metaphyseal
any
corner
fractures
fracture.
here?
I'm looking actually for metaphyseal corner fractures, maybe on the left, on the right side, on the right humerus, femur, on the right side.
Okay.
Maybe there is a metaphyseal corner fracture.
Thank you. This is another patient with abdominal pain. Can you scroll?
Okay. Okay, this is an axial cut of the abdomen without contrast. I'm scrolling from the first cut down, taking a general look. I can see there is fluid-filled dilated small bowel lobes. I'm trying to see what is the cause of this dilatation. It is fluid-filled. So I'm scrolling to the end of there is an obturator hernia on the left side, which causes obstruction. So this is a strangulated obturator hernia causing a small bowel obstruction.
Anything else you
So
want to comment on?
Yeah, I'll look for the long window to see if there is perforation, and I would urgently refer this patient to the surgeon on call for proper assessment.
Anything else you want to comment on?
Okay. Yeah, I would be looking for if there is. I would look for the vascular tree if there is in the contrast study.
You are
for the vascular
scrolling or
tree.
not scrolling through the image?
I'm scrolling. I'm scrolling now. But
because on our end, the image is static.
in the contrast, if there is contrast study, I would be looking at the vascular tree. I'd be looking if there is portal venous gas and the pneumoperitoneum. This is red flags I'd be looking for in this study.
This patient has pelvic pain radiating to the back.
Pelvic pain radiating to the back? Okay.
Yes.
So this is a sagittal T2 weighted images of the spine. I'm scrolling to see whether through the images. So I can see there is lower. Just 1 second, because the scrolling. Can you scroll for me? Because it jumps. The scrolling.
You can use the keyboard up and down.
I'm using the keyboard. I'm using, but it's jumping.
Yeah. This is the radiopedia images.
Okay. Okay. So I can see there is L45 and L5S1 mild disc lesions. I can see there is a fluid-filled structure which is seen adjacent to the uterus. It's probably within the adnexia. I'll be looking at the axial cuts.
What do you mean by fluid-filled?
It's a cystic lesion. Cystic lesions. It's high signal on T2 here.
Can you describe it more?
It is a well-defined cystic lesion of high T2 signal. It is adjacent to the uterine cavity, so it's probably within the adnexia. It doesn't have any relation to the bone. From the sagittal view, I cannot see any relation to the bone. I can see the rectum compressed. So I will be looking at the axial cuts to see if there is localize the lesion and see further characterization. If you have, can I look at
what possibilities do you have for this lesion?
I'll be thinking for this lesion of ovarian cyst. I'd be thinking also of mostly ovarian cyst.
Can you bring the images to the lesion again?
Okay. Here, this one. This one.
So what do you feel it could be?
Maybe it's an ovarian cyst.
Anything else in your mind?
There's I would like to see the signal on the other sequences, if it's fluid signal or maybe it's a lesion in the rectovesical. It may be fluid in the rectovesical pouch, but it is well defined, so it's not fluidy. So it may
Yeah,
be
this is
if
free fluid. Don't worry. Yeah, this is free fluid.
it's free
About
fluid.
the
Okay.
lesion, yeah,
So
what are the possibilities for the lesion?
what is the possibilities for the lesion rectovesical pouch?
Yeah, you mentioned that there is a lesion in the left adnexia, this one.
It may be something like something coming out of the spine, like
No, the spine is clear. You have the periosteum of the sacrum is normal.
okay,
Yeah, please stop scrolling.
Okay.
Hmm?
I'm not sure actually
Any
about
other
the other
ideas?
No, I don't
Differential
have
diagnosis? What you are concerned about?
I'm concerned about maybe an abscess, maybe in this area. If it's there's a fistula between the rectum and
You
the
mentioned it is related to the adnexia.
yeah,
Hmm?
yeah, it's related to the adnexia.
Yeah.
Yeah.
So
So other possibilities, it's either a tumor within the ovary, or so I have to see the T1 signal, or it's a cyst. So
okay, no
maybe
problem.
it's yeah.
No problem. Thank you. We have another patient has cough.
Okay, I'm presented with the frontal radiograph of a patient with who has cough of the chest of an adult patient. I can see there is signs of volume loss, mild volume loss seen within the right hemithorax. I can see also there is an opacity seen.
There is no volume loss. Where is the
Okay.
opacity?
I can see opacity. It is in the superior mediastinum. It is surrounding the trachea from both sides. I can see it
Where
doesn't.
exactly in the superior?
In the anterior mediastinum.
Why you mentioned
Anterosuperior.
it is anterior?
Because it does not cross the clavicle, so it's not posterior, and I can see also the aortic knuckle, so it is
So what could
anterior.
it be?
I think it's continuous with the soft tissue in the neck, so it can be retrosternal goiter.
What you will do next?
I will do a neck ultrasound to see if the patient has.
Okay, thank you. Thank you. We finished the cases. Thanks a lot. Candidate 3.
Thank you.
Candidate 3 ready?
Yes.
Okay, just a second. No, stop controlling the screen. Candidate 3, you can request the remote control. Request remote control.
Let me see.
Request remote control, or the host, you can give the remote control to him. Candidate 3.
Sure, I'll do this. I'm doing this. I'm just doing.
Okay, thank you.
Thank you.
The other candidates stop remote control.
Are you able to find the candidate 3 any option for remote?
Yeah, the
control?
unmuted one, please. I know I have two, but this is one from the laptop and one from the iPad.
That's okay. Breakout. Call. Just a second.
I think you gave me.
Yeah, I think I've given you. Just you can try once. You can try if it's you're able to. Good.
Can
You're
try
good?
now?
Let me try, please.
Yeah, click on the
Sure.
screen. Click by the mouse and then try to go up and down.
I think I didn't got it yet.
Not yet.
You can request it by yourself from your end.
I don't know why it's not appearing. Okay, you
Accept.
are giving the
Yeah.
other.
The
Please give
other
me
one.
the account, please. The unmuted one. Sorry, but this is one from the phone and one from the laptop. Sorry for this.
That's okay. But are you able to get the screen controls?
What is the other name?
It's the same, candidate 3. Candidate 3, candidate 3. Both are candidate 3.
Oh, I have only one candidate 3 on my screen.
Okay, just hold on a second. Something. No,
I
not
prefer
yet.
to log in by one device only, if you can.
Okay. Okay, so let's try the another the first one you gave me the
Because in the exam you have only one device.
Yeah, probably that can be.
sorry, you can now give me the other one. I'm sorry, but because I have a problem in the
You are ready now?
you could try again giving me the remote.
Accepted.
I don't know what happened.
We call it candidate 3? No, not yet.
I don't know what happened. Tap here to your remote. Supposedly.
Through Zoom, you have this icon. Request remote control.
Where can I get it? Actually, you
have
give me
icon of
I got a
chat.
message that Dr. Mahmoud is trying to give you the remote, and I clicked the screen as usual, but I don't know what happened. Then someone else is moving my mouse.
I've sent it again to candidate 3.
Okay. Okay. I don't know. I'm not sure why it's not.
Mahmoud, can you scroll for just for if it's feasible, if you are comfortable? Probably she's struggling with this.
Or you can start with the
appears-
candidate 4 until I make the issue.
As you like. It appears
Because,
on my side
I
that
think-
candidate 3 can control your screen.
This one, the unmuted one, right?
I don't know which one.
Okay, but let me. Your remote control is revoked. Sorry, doctor. I'm so sorry. Could you just try the another account? I will look out from this one, or I will mute. Because this is the last trial. Could you? I'm so sorry for the inconvenience.
We need only one account. You are ready now?
Hatem, you please give me here to this unmuted account. Again, please.
I have only one account from my side. Remote control, candidate 3, and...
No, you are giving the other one. This one I'm talking is an unmuted one. I can change
log
it.
in by one device?
Yeah. So, Dr. Mahmoud, I have just made one candidate 3. I've removed everything else.
Okay.
So now you can check, Dr. Mahmoud, if you can see.
I give it to candidate 3 now.
Okay, now candidate 3, please check if you're getting some signal.
Yes, finally.
Okay, I will start at the time. This patient has post-traumatic amnesia.
Post-traumatic amnesia?
Yeah.
Okay, so I'm presented with brain MRI FLAIR sequence for a patient who is presented with post-traumatic amnesia. I'm scrolling through the provided scans before start commenting. There are tiny non-specific flare, bilateral white matter, and centrum semi-oval signal intensities. I think it's a non-specific. Here in the foramen magnum,
where they are these hyperintensities?
Bilateral white matter, deep white matter, and high in the centrum semi-oval. And
any other places?
And I think they are sparing the subcortical here, yeah, in the high centrum semi-oval, deep white matter mainly, and a linear distribution. Yes, and there is mainly in the frontal and parietal. There is a focus in the left periventricular region. In my routine practice, I'd like to see that after finishing the axial slides, I'd like to see them on the sagittal as well to see better.
What do you think they are?
Distribution and the relation to the actually the bilateral white matter signal has wide differential. It could be demyelinating process. It could be if the patient is known, or yeah, if I think it could be just vascular or related to old microischemic arteriosclerosis.
The patient is still young.
If the patient is young, so I'm going with the category of could be vasculitis, demyelination, or I'm trying to linking it to the history provided.
What is the history?
Post-traumatic amnesia.
So, what would it be? In the light of this history?
Yeah, I'm trying to link them to, actually, just let me check the corpus callosum before. I think there is nothing in the corpus callosum. Okay.
Why you check the corpus callosum?
Because I'm afraid if they could be part of a severe trauma-related injury like diffuse axonal injury. So I want to just make sure of the clinical status of the patient. Again, the axial SWI and DWI sequences if
we
available.
have the SWI, yeah. This is the SWI.
This is the SWI for the same patient.
Yeah.
So I am looking for any glooming artifact, which in fact they are at the corresponding sites. So this is confirming that these are hemorrhagic foci. So in the clinical context, this is a diffuse. I will consider it diffuse axonal injury. I would check the sagittal. I would check and alert the treating physician about the findings. And
okay.
Yes.
Thank you. This patient has thumb pain.
Thumb pain. Okay.
Yes.
So this is a lateral thing.
This
thumb
is frontal,
and
yeah. Frontal
so
radiograph
frontal.
of the
Okay,
thumb.
the thumb. Yeah, frontal of the thumb. Frontal radiograph of the thumb. I can see that actually that there is joint disease in the distal interphalangeal.
Why you mentioned joint disease?
Because I am seeing or periarticular actually. Let me. I think the picture is a little bit pixelated. If you can wait. Okay. So there is. Let me try start again. So this is a frontal thumb radiograph. I can see that there is surrounding, there is the problem is in the interphalangeal region, where I can see that there is subchondral lucencies and subchondral perosteal bony like proliferation. Can see that there is also evidence of tissue swelling. I cannot see frank lesion, but there is there is frank soft tissue calcification. I think the proximal joint is normal and the other are normal. So this is
normal
an aggressive.
of what? I didn't hear you. Repeat it
I mean
again.
the other, no, the visualized part of the fingers are normal. So the problem is in its aggressive process within the joint or within the proximal.
So this is a
within the
joint
distal
disease
intercostal.
or bone disease?
I think it's a subchondral
This is
bony disease.
a joint
Bone,
disease or bone disease?
I think it's a bone disease
Where exactly it is?
in the subchondral aspect of the middle phalanx with
The,
pathological fracture
there is no middle phalanx in the thumb.
in the proximal
The
phalanx.
proximal phalanx, so it is mainly in the proximal phalanx.
No, in the subchondral aspect of
And
the
the distal phalanx is normal.
no.
So it is
So I
affecting
think
the proximal and the distal phalanges.
yeah.
So it is bone disease or joint disease?
It's a joint disease, could be infectious or an inflammatory or a joint septic joint arthritis or
So
mainly
this is
because
your
affecting
final
both
decision.
joints of the. Yes, I would
What you
like
will
to see
do
the
next?
orthogonal view. In my routine practice, I'd like to see the orthogonal view. I'd like to see the clinical data of the patient if there is a fever,
What
leukocytosis.
you will do next?
I will do MRI for this patient.
What else?
After correlating with the previous, checking the previous, and I think
Anything else you will do?
sometimes we use bone scan to see specifically if there
Okay,
is
no worries.
what
We have this patient has abdominal pain. Check the remote control.
I'm scrolling.
Yes.
It's not moving. Okay.
You just
Let me
moved
start.
it.
Maybe it's moving. Okay, yeah. So I'm presented with axial CT scan. Could you? I didn't hear the history. Sorry, because I
Abdominal
was
pain.
concentrating. Okay, for a patient who is presented with abdominal pain, so I am scrolling through the images and I am trying to see the cause of that abdominal pain. The first thing I see that there is a hernia within the left inguinal region, or it could be femoral actually because it's lateral to the pubic tubercle. I'm trying
Is
to
inguinal
trace.
or femoral?
No, it's related to the femoral vessel, so it's femoral, and I am trying to see the hernia sac itself. There is minimal fatty stranding. I'm trying to trace it up and going with the affected bowel segment. So
which part of the bowel is dilated?
Yes, yeah, I'm trying to figure this out. The dilated, this is a small, this is a, I think this is the large bowel. Let me check again, sorry. Okay.
This is the small or the large bowel?
This is the small bowel.
Small bowel dilatation?
Yes. No, actually, this is the large. This is the large bowel.
Final decision?
Yes, this is the large. That's our house tree, and I'm trying to see down. Okay. Actually, in my routine practice, I will trace the bowel from below to up, and we'll check this in the corona. This is the sigmoid. This is the let me check. This is the hepatic fracture.
So in conclusion,
literally,
what is your conclusion?
Yes, this is a left femoral hernia causing bowel obstruction. I want to see in the my routine practice. First of all, I want to change the window to the pulmonary pulmonary or lung window to see if there's a free gas locules, because I'm suspicious. Yeah, I want to change the window to make sure that there's no free gas locules. Some locules there in the right iliac region, subhepatic. and want to see there is no free fluid actually, and checking the mesenteric vessels and the portal veins to see. I think this is an incidental granuloma in the liver, and also I want to
You will
see
check the vessels in non-contrast?
yeah,
Yeah?
no, I want to ask for contrast to check the
Oh,
vascularity.
So what is your conclusion here?
Femoral left femoral hernia causing bowel obstruction.
Which part of the bowel?
It is the large bowel.
What you will do next?
Contrasted CT
Hmm?
and alert the treating physician.
Hmm?
They treat the surgeon to operate.
Hmm?
Also, the hernial sac, there is fatty stranding within the hernial sac, so this thing, it's a strangulation also. This is clinical information. There's information they have to know also.
Okay.
And
Why they have to know what it will add for them?
because it's impending ischemic or starting to change to ischemic
Okay.
bowel.
What do you
Ischemic.
think is happening here?
I think in this frontal radiograph of a pelvis for a skeletally immature patient that there is a flattening of the right acetabular angle. There's asymmetry of both femoral epiphyses being smaller on the right, where it's also lateralized. If I try to draw the Shenton line, it's disrupted on the right, and also if I'm drawing, and also there
So
is
what is
abnormal.
this?
So this is a developmental dysplasia of the right hip. I would alert the treating physician and the orthopedic surgeon. The patient
Okay.
need to be treated and for
In
follow-up.
other situation, other patient, if the acetabular angle is normal, if the acetabulum is well formed, what else you have in your differential diagnosis for such a case? Not this case.
Yeah. Maybe large fusion
From
causing
what?
the septic arthritis with large effusion causing
Okay.
displacement of the
Okay, thank you. We have ultrasound for the groin. Can you scroll through it?
scroll through ultrasound of the groin. Okay. Okay, so this is ultrasound of the groin region. This is the left region. And let me scroll through the whole images. And this is the left inguinal region. Okay, so in the left inguinal region, I can see that there is increased vascularity within the scrotum, testis, and also the subcutaneous tissue with associated linear subcutaneous echogenic foci with reverberation artifacts indicating air foci. So I'm worried about this air. I'm worried about with the marked increased vascularity. I'm worried about inflammatory changes with
What you will do next?
emphysematous changes. I would correlate with the patient, with the clinical patient, because this is an urgent condition. I'm thinking that I want to see the extension first of all, if it's reaching the
How
perineum
you
or
will
just
see the extension?
if after alerting the physician, I can do CT cross-sectional imaging
We
to
have the
see.
CT images here. Let's go through the CT. This is the CT.
Okay, so the CT for the same patient in the perineum region saw extensive emphysema involving the left perineum and the groin region, as well as the left scrotal area with marked inflammatory changes in form of fatty stranding and minimal
So,
fluid. So this is for gangrene. This is an
what?
urgent condition. It should be debrided immediately. So I would
Okay.
alert the treating physician
Thank you.
and see the superior
Yeah.
extent of the.
Yeah, thank you. Time is up. We have candidate 4.
Yes.
Yes, we have candidate.
Okay. Can you ask for the remote control, candidate 4? Approve. Thank you. This is the first case. This patient came in trauma. I will start
So
the
this is
timer.
axial brain CT without IV contrast. I will go through the images first before commenting. However, I can see multiple parenchymal hematomas So I can see there is large frontal hematoma with surrounding edema. There is also another two, one in the
Where
right
is the
temporal
edema?
region surrounding the right frontal
Where it
hematoma.
is?
It's right. Can
The,
you see my arrow?
the edema is hypodense or hyperdense?
Hypo. The hyporim here surrounding the hematoma.
Anything
There is
else?
also right temporal hematoma and left temporal hematoma. There is also large because extra-axial hematoma, because it is crossing the midline. I'm suspecting it to be epidural. However, it could be bilateral subdural hematomas. There is no midline shift.
No midline
I
shift?
can see.
What do you
Maybe
mean by no midline shift?
there is a slight midline shift here and on this cut.
Where exactly it is?
I can see if I draw a line from anterior to posterior, the pharynx cerebral, it will be slightly deviated toward the left side,
Indicating what?
indicating mass effect, and this is an emergency. I will immediately call
Why
the treating
emergency?
physician because it could result in brain herniation.
What kind of brain herniation?
Because of this hematoma, it will cause subfalcine herniation. Also,
What is
ankle
the consequence for the subfalcine herniation?
it will compress the anterior cerebral artery.
Okay. What
And
else? You
maybe
mentioned there is ankle what?
ankle herniation.
Where
It
it
could
is?
cause ankle herniation. It is at the level of midbrain. I can usually when there is tracing of ambient cistern, I will suspect it. However, in my routine practice, I will review it in coronal image. However,
So what
here
is
I
your
can suspect
conclusion?
there is multiple brain hematomas and frontal epidural hematoma. There is also left subdural hematoma. This is causing mass effect manifested by midline shift and suspicion of subfalcine and ankle herniation.
What you will do next?
I will immediately call the treating physician because this patient need immediate intervention to decrease the compression and the intercranial compression, either by medication or decompression of the hematoma.
Thank you. Which side is this mammogram?
This is left side.
Okay. Can you see any abnormality here?
This is craniocaudal view of the left breast. It is densely fibrogranular tissue. I can see microcalcification seen in the outer part of the breast. Also, there is microcalcification seen in the inner part. There is no nipple retraction, no skin thickening. In my routine practice, I will review also the MLO view and use compression and magnification views.
How do you describe this calcification?
This is scattered microcalcification, regional in the outer part, and segmental microcalcification scattered also. I
Do
can't
they have a
see
specific
any.
shape?
I can't recall a specific shape.
Hmm. Okay. You mentioned that you will look for the other view. And what else?
Yes. And use do ultrasound.
Ultrasound. We have the ultrasound here.
So this is a selected image of ultrasound of the left breast at 10 o'clock. I can see there is hypoechoic lesion. It appears slightly microlobulated. It is appear wider than taller. There is within the lesion itself there is few hypoechoic foci suggesting calcification. There is no posterior acoustic shadowing or enhancement. In summary, this lesion is suspicious of malignancy. In my routine practice, I will
Anything else
advise
you will do?
I will examine the axilla and the rest of the breast also, and the other breast also.
Yeah. You will recommend any other imaging?
I will recommend biopsy.
Directly to the biopsy? You will not need any other imaging?
The findings of this lesion for me, it is highly suspicious of malignancy. So I will proceed with biopsy.
Okay. We have this nuclear study for this child. Can you see any abnormality?
I can see increased uptake on the right posterior ribs. There is no other increased uptake in other ribs or the appendicular bones. The findings could be due to fractures. In that case, I will alert child protective service for a non-accidental injury.
Okay, thank you. We have this patient with abdominal pain. You can scroll through the images.
Okay. So this is axial abdomen and pelvis CT scan of adult patient presented with pain. There is IV and oral contrast. Is it it is only pelvis CT.
Is there any
So
abnormality?
I can see there is I am suspecting an abnormality seen in the cecum. However, I will take a moment to
What kind of
examine it.
abnormality?
I can see slight wall thickening. However, I am suspecting of dilated tubular structure arising from the cecum. This could be appendix. I will try to follow it if
It
it
is
is
not
blind-ended
infinite.
or okay.
What else in the cecum?
I can't appreciate the wall. I'm worried of ischemic colitis.
Why ischemic?
Because I can't see wall enhancement.
You mentioned any abnormality in the vessels?
I will re-examine them. Actually, no, I can't see any abnormality.
So what is in the cecum?
There is multiple air foci seen outside the lumen. However, I will.
So what they are?
This could be diverticulitis complicated with
Yeah,
perforation.
yeah, good idea. What else other than the colon? Is there any other unrelated abnormality here?
I can see prostate enlarged.
Prostate, yeah, good. Can you describe it more?
Okay. So the prostate appears enlarged in size. I can't see within it any sort of calcification. However, I can see there is slight hypodense area in the anterior right side. However, I am not sure if this true lesion or from pluming artifact.
Lesion like what?
This could be prostate cancer. And I will examine the bone if there is any bony lesions.
Yeah, let's bring the bone window. A good idea. What do you think is happening in the bone?
So I will go through the bone before discussing the. So I can't see any bony lesions. I don't see any osteoblastic bone lesions. I don't see any osteolytic also.
Are you sure?
I will re-examine. However, in my routine practice, I usually
No,
recheck
from
them
these
on the
images
sagittal.
only. Do you feel the bones are comparable in each side?
I can see after rechecking, I can see the right side is the bone density is slightly more than the left side.
Indicating what?
Because there's no, it could be metastasis, and if I consider the
What kind of metastasis?
Osteoplastic. Osteoplastic.
Sclerotic.
Sclerotic.
Okay. Could it be Paget disease?
That's a differential. However, I don't
in
see
this case,
enlargement of.
yeah.
I don't. In this case, yeah, but
Could
however,
it be Paget?
It could be. However, I don't see a cortical thickness or coarse trabeculae.
So you don't see the signs of the Paget. How it could be Paget? What is your final decision?
There's first multiple free air in the abdomen, air foci surrounding the cecum. This could be perforation from diverticulitis. There is also suspicious prostatic lesion with the increased right side of the pelvis bone density, suspicious of metastasis.
So it
no
is not Paget?
cortical thickness. Yes, because no.
Thank you. So our last case, do you see any abnormality here?
This is a frontal radiograph of adult female patient. I can see there is like some silhouetting of the left cardiac border.
Indicating what?
Indicating obesity in the mid-lingular.
What could be the
part
cause?
of. It could be in if the patient presented with cough and fever, it could be pneumonia.
What else? Any other possibilities?
There is
could it be a collapse?
It could be collapsed. However, it is unlikely because there is no volume loss.
Which part of the lung? Which part of the lung contain this abnormality?
The lingular segment of the upper lobe, of the left upper lobe.
The lingular. So your final decision: consolidation or collapse?
Consolidation.
Okay, thank you. Thank you. This is our last case and our last candidate. Really thanks all of you. I'm so sorry to be a little bit tough or pushing you. I am not this bad personality in the real life, but I have to do like that to give you the real exam feeling. And this simulation is the only way to succeed the exam. You must put yourself under pressure. You must train with one or two colleagues every day to see cases, to present the cases. You can see all the cases. We already know, all of us, we already know the diagnosis of most of the cases, but most of us didn't get high marks. This is the problem. You must describe first. Describe very well, really, because bad description will end in a bad decision or bad or not or wrong diagnosis even. So description is your key. We will go through the cases rapidly. We'll start from backwards. This one, as candidate 4 said, this is a silhouetting of the left heart border, indicating opacity, underlying consolidation of the lingula. The lingula does not collapse because it is part of the left upper lobe, so there is no partial collapse. This is the whole lobe should be collapsing, or you search for other possibilities like consolidation. So never to mention collapse with lingula. A good job. The previous case of the CT abdomen, yeah, please make sure that you go through all the organs visualized in the images. I agree that there is multiple diverticuli here. Some of them may be inflamed, and there is a little bit fat stranding around. Don't mention an interpretation without mentioning the description for it. So he put the possibility of ischemic colitis or ischemic disease, but he didn't mention anything about the vessels before. So don't do that in the exam. You should describe everything, and from your description, you go to the interpretation and diagnosis. Make sure that you see everything as you saw in this case. There is a prostatic lesion here concerning for prostatic cancer, and you must ask for the bone window, and please be specific, be confident, don't hesitate, describe very well, and then interpret your description. So if you described it very well here, that there is some increased sclerosis of these bones on the right side without bone expansion, without thick cortex or coarse trabeculae. So this is definitely sclerotic metastasis. This is not Paget disease. If he asked you, he wants to make sure that you understand the pathology of the diseases. You understand the differences between them. Don't hesitate. Explain what is in your mind, what you are seeing exactly in this case, not in the books. Okay, this was also a good case. This case, he did it very well. You can see there is increased tracer uptake in the right sided. This is from the back, so this is the right side. Posterior ribs in this young age group, you must go to the non-accidental injuries, and you saw I bring it a lot of non-accidental injuries situations and images because this is a very high yield topic in the exam. And unfortunately, if you failed in a case like non-accidental injury or any emergency case, you will fail the whole VIVA session with the two examiners. So be careful for that. For the mammogram, if there is no marker here, you can confidently say the side of the mammogram. Is it left or right by looking through the nipple? If the nipple is looking to the left side, so it is left. If looking to the right side, so it is right. And you must start by mentioning the view. This is craniocaudal or mediolateral oblique. You have checklist also in each exam. In mammogram, you must start by the main abnormality. Please describe it very well. What is it? How it looks like? What is the number? Where exactly is it? For the calcification, please don't forget pleomorphic. Pleomorphic is the magic word to indicate that it is suspicious. Pleomorphic means that it has different shapes. So this is suspicious calcification, not any other calcification. Don't be present in any incidental finding like that. There is a retroareolar cystic lesion here. So if you are present here and you didn't scan the rest of the image, you will not see the calcification. For the management, you must complete the exam by looking for the other view, the previous images, the other breast, and then go through the triple assessment. He asked for the, also I forget the important negatives here are the skin, nipple, and axilla. You must comment on them. Even if they are normal, you must comment. For the ultrasound, describe it if you are going in the way of malignant lesions. So describe it by the same buzzwords and the same way they describe it in the books or in the reports. Like here, you must mention the margin, the surface, the posterior acoustic, the calcifications, and please, in the ultrasound, never, never, never finalize your answer without mentioning that you will scan the axilla. For this case, also, you can see there is multi-regional or widely distributed pleomorphic microcalcification. So please, you must add MRI exam. If there is multiple lesions, if they are bilateral, if they are in different quadrants, you must add MRI exam in your management. If you have previous operation, previous neoadjuvant chemoradiotherapy, if the patient has breast implant, all of these are criteria for indication for MRI. If they bring the MRI like that in the supine position, so you have this is the similar way in all the cross-sectional images, that the left side on this left and this is the right. You can also look for the liver and the apex of the heart. If they bring the images in prone position, so be careful to mention the side correctly. And in the MRI, you will go through all the checklist again, both breasts, the axilla, the skin, the nipple, and don't forget to ask for the enhancement curve. This is also very important. For the CT brain in the trauma, so if you bring a medical student, candidate, he will mention that there is a hemorrhage and he will mention that there is abnormality here, definitely. But you are a radiologist and this is exam to be a consultant radiologist. So this very crucial and very important for you to pick the emergency finding, the red flags, because this, like in this case, the examiner pushed you to say the important items. What will happen if the examiner didn't ask you or he didn't help you? And anytime the examiner help you or prompted you, so make sure that you are losing marks. And no need for that, because you already know the diagnosis of the case. You already know the main findings. So no need to lose marks in such easy cases. The first thing here, you have a contusion really, but if you can see, there is a differential density within the contusion. There is areas more hyperdense than the other areas. So this is highly suspicious for active bleeding, active ongoing process. So this one is very, very high alert, very important to call the surgeon now to decompress this brain. Also, the herniation is fatal. If you didn't tell them about the herniation, the examiner spend around 1 minute to push the candidate to say that there is a subfalcine herniation. This is not usual in the exam. In the beginning, you mentioned there is no midline shift. Please don't do that. Don't be very fast. You are not in a hurry. Take your time to describe the things first, what is happening. And then this is the subfalcine correctly mentioned, and then the basal cistern is effaced. So definitely there is a uncal or transtentorial herniation. Also, this is very bad herniation. What you will do next, this is a very, very urgent exam. I will show you This is in the second day. See the contusion rapidly growing like that. See in the after 1 week, the patient going through very large contusions, and see the brain itself, diffuse brain edema. There is no sulci. Even the gray-white matter differentiation is very bad. So please, the emergency cases are fatal in the exam. Okay, let's go through the candidate 3. Candidate 3, yeah, did this case very well from the ultrasound, hyperechoic foci and the ultrasound, not only stones, but please consider the air foci, especially where there is increased vascularity, so there is underlying inflammatory process with air foci, so it is emphysematous. The important thing here, the red flag here, is to exclude the air extension to the perineum, because the perineum is for knee gangrene. This is a fatal scenario, and it should be surgically debride at once. The prior one was very easy also, the DDH. The hallmark of the DDH is the acetabulum deformation. Okay, you must look for the acetabulum first, the acetabular roof, the shallow itself. It is very shallow, the groove, and this is a simple case of DDH. And don't forget the septic arthritis. For the abdomen case of the hernia, please don't hesitate. Don't show the examiner that you don't know what you are saying, you don't know what you are searching for. This is very bad, and this is not real, because all of you are very smart. You have a very good experience in radiology. You're already doing these cases many times in your day-to-day practice. So be confident and show this confidence to the examiner. He don't know you. You are the one who present yourself, and the marks are according to your presentation, not according to your certificates or your experience or anything else. Definitely, this is a large bowel. In no time, if you stopped here in the middle of the abdomen, look for the colon. Where is the colon? The colon, the ascending and descending colon are enlarged. The small bowel is central. It is collapsed. So this definitely, without thinking, this is a large bowel obstruction. And please, you have a checklist. You should mention it. We are not diagnosing the case to the examiner. He already knows the diagnosis. He wants to see how you diagnose the case. What is your approach? What is your important items or checklist to mention in this such cases? You are searching for free air, you are searching for free fluid, gangrenous part, you are searching for any vascular problems, you are searching for anything related to the main abnormality. Please express your way, how you are going through the cases in your day-to-day practice. We are not diagnosing the case. If you are writing a report here, you will not write large bowel obstruction due to left femoral hernia and follow stop. This is one line report. It never happens. So please show your approach and mention the rest of the checklist. This is your marks. Anything you will not mention, he will not give you the mark for it. And for easy cases like that, you can get easily 8 from 8 in this case, but unfortunately, you are going to get 5 or 6 in an easy case like that. And for the hard cases, for the differential diagnosis cases, you already will lose marks in it. So overall, you will lose marks in all the cases. So overall, not good performance. And this is not true. So please, in easy cases, do your best to get a very high marks. Also, yeah, don't forget the contrast, the coronal, the lung window, and you should mention all of this to the examiner. And this one also, for the thumb, please be confident. You must describe things very well, and then you are on a track. If you choose from the beginning a wrong track, so you will go to the wrong end. So this is a bone disease or joint disease. This is an aggressive process or non-aggressive process. All of this matters. So you mentioned that there is abnormality here in the proximal phalanx and also abnormality in the distal phalanx. So this abnormality is on both sides of the joint. So definitely it is a joint disease. And there is destruction, there is swelling, there is leucences. Please don't forget to mention the septic arthritis. Again, this is emergency. And the first case for the age of the patient is still very young, and he gave you the history of trauma. Please prioritize your differential even. You must mention the most relevant one or the most compatible one with this exam, with these images. So if you started by the demyelination, you will lose marks. Started by anything else other than suspicion for diffuse axonal injury, you are losing marks. Even if finally you reach the diagnosis, but you lost marks easily without no gain, and you will lose marks in harder cases. So it will ends up you are losing marks in all the cases, and this is not good practice. So for the diffuse axonal injury, you have the history of trauma. This is a young patient. The patient has symptoms, amnesia or disturbed consciousness or any other kind of history. You are searching for cortical lesion, gray white matter junction lesions, corpus callosum lesions, basal ganglia lesions. And the gold standard is the SWI, and it is definitely more clear here that there is lesions scattered and even in the splenium of the corpus callosum and also in the white matter and everything else. Let's go to candidate 2 cases. I don't know why candidate 2 was going very fast in the images. You are not in rush. You are not in. We are not running after you. You should have your time because this is your time. You have 15 minutes with the examiner. If you end the cases in 10 minutes, so you are losing marks and you will not go anywhere else. You are staying inside the exam room to finish your exam. So please don't be in a hurry. Don't go very, very fast through the images. You will lose marks without any gain. And be confident, describe very well, be specific also in your description and in the especially the site, the exact site of the abnormality. And this is definitely superior mediastinum anterior part because it fades away over the above the clavicle. So this is the cervicothoracic sign. So this extending from the neck, mostly from the thyroid gland, especially the trachea is deviated. So I agree with everything you said in this case. Let's see the previous one. Yeah, this is this emergency case. And if you fail in one emergency case, you will fail the whole session of the VIVA. Anything related to the adnexia, please exclude the red flags, exclude the emergencies. What are the emergencies related to the adnexia? The most high yield, the most common emergency here is the ovarian torsion. So please exclude it first. If you describe the lesion from the beginning in a good way, so you will end in a good differential diagnosis or even good diagnosis. So this is over. You can see the peripheral follicles, and the examiner asked many times, stop scrolling and show us where is the lesion. This you should do that in all the cases, really, especially the scrollable ones. You should stop on the main concern or on the area of main abnormality. You should stop scrolling and put it on the screen and describe it to the examiner. Don't speak while you are scrolling. He wants to concentrate with you and see what you are describing. And this also easier for you if the image in front of you, if the lesion is in front of you, definitely you can see the peripheral small follicles here scattered all over the periphery of the ovary. So the ovary is enlarged in size, engorged, and has peripheral follicles. So you must mention that there is possibility of ovarian torsion. And the examiner tried many times to push the candidate to the prompt the candidate to suspect any other things, and please take the help of the examiner. The examiners are helpful. They will mention the relevant history, and any questions from them from their side is important also, and they are guiding you to the right path. They are not deceiving you. Okay. For this case also, we are not diagnosing the case. We are describing and showing our approach. What is our checklist? What are the important findings? We can finish the case, all the cases, we can finish each case in less than 1 minute. This is a hernia, this is a hemorrhage, this is tumor, this is torsion, and we can finish the whole exam in 10 minutes. But this is not the scope of the exam. You must describe everything first. You must show the examiner your approach and your concerns and how you will go through the cases in your day-to-day practice. Yeah, we all already know that there is left obturator hernia here, but you stopped here and you didn't go through the images. The examiner asked to go through the images at the end. You should do this from the beginning. You should describe first that there is a large bowel. You can see the collapsed colon. You can see it here, the collapsed colon. So this is a small bowel obstruction. You must comment on your checklist for bowel obstruction: the free air, free fluid, the bowel wall, the portal venous gases, the vessels. You will ask for a coronal images. All of these points are very important, more than the diagnosis. Anyone can diagnose the case, but we are not looking for only diagnosing the cases. Please show your approach. Okay. This one was very good. The left hemithorax is opacified and there is fractures in the lateral ribs in this young age. There is also fractures here. This is the buccal fracture, distal radius and ulna. There is a fracture here. You can see the difference between the fracture and the sutures. And also, this is a true fracture. Be confident. Don't show the examiner that you are hesitated, that you don't know what is this, but there is a definite fractures in both femur here. And for the first case, please don't lose marks, especially in the cases that you know already the diagnosis. The examiner asked for the cause, and you start mentioning the cause from the books. He wants the cause from this case, from these images. And without his question, you should describe everything from your side first, so he will not need to he don't need to ask you anything and put you under pressure, and you feel you are stressed and you start losing marks. No need for all of this process. So there is aneurysm here in the APOM, and there is this is not only edema. This absolutely this is infarction in both ACA territories. Because of the spasm, because sometimes it happens subfalcine herniation. There is also subarachnoid hemorrhages. If you do the angiogram, there is aneurysm here. See, after 1 day, the whole ACA territory on both sides are infarcted. So please, you must pick the red flags very fast from the beginning. And don't go very fast through the case. Take your time. For the first candidate, what was this? Yeah, this is a very important case, and never fail in emergency case. Please, where is the gray-white matter differentiation? No gray-white matter differentiation. Where is the sulci? No sulci. What are the hyperdensities? This is the pseudo subarachnoid sign. See, this is the tentorium is very dense. The tentorium is very dense. Why? Because the brain is very hypodense. There is loss of the gray-white matter differentiation. There is diffuse brain edema. All of this, you must mention it. You must mention them. And the conclusion of diffuse brain edema, diffuse hypoxic ischemic encephalopathy, all of these are very important to mention. And for the skeletal survey, you are looking for metaphyseal coronal fracture, and you have one here. So please, for the non-accidental injuries, see as many cases as you can. And always in pediatric images, suspect non-accidental injuries. Even in your mind, look for the signs for the non-accidental injuries. We missed a case, I think. Yeah. This case also, please describe very well. You have 9 items for description for a bone lesion in the X-ray. If you divide them 3 by 3, 3, the first 3 is the bone name. Don't forget to mention the bone name and the exact site of the abnormality. Is it diphyseal, metaphyseal, epiphyseal, and is it eccentric, is it cortical, medullary, the exact site, and the number of the lesion, is it solitary or multiple. The second 3 set is MMM, morphology, matrix, and margin. The margin is wide zone or narrow zone. The morphology is sclerotic or lytic or mixed, and the matrix, is it osteoid matrix, chondroid matrix, or ground glass matrix? And then the last 3 are related to the cortex. Is there any periosteal reaction? Is there cortical breach? Is there soft tissue extension? You must mention the points, how you describe the lesion, so your interpretation will be this aggressive lesion. But if you didn't describe it very well and you interpret it even in a good interpretation or a good diagnosis or a right diagnosis, you also lost some marks without any gain. And you already know the information, you already know the items, so you should go through them. And definitely this aggressive lesion, it could be osteosarcoma, it could be osteomyelitis, but here you can see there is a Codman triangle, there is cortical breach, some osteoid matrix, and always for the osteosarcoma, there is 4 main items in the management: MRI, including the whole bone, bone scan, CT chest, and sarcoma center for biopsy. For the management part, please mention the management. What will happen? If there is pneumonia, so you will give the patient antibiotics and follow up. If you need another images, you ask for the images. Don't only inform the referring physician. Tell the examiner what will happen to this patient, what the referring physician will do for this patient. This is the management. This is the only way that you will gain marks in long and in VIVA. And for this case, yeah, this was a femoral hernia, strangulated femoral hernia, incarcerated, and you can see it is going along the femoral canal, and see the bowel is going through the hernia from here, herniated, and you must there is a little bit small bowel dilatation in the pelvis. And please don't forget to mention all the items. You can see the gallbladder. There is a gallbladder stones, and you can see the gallbladder is very large, very dilated. It could be mucocele. Sometimes there is superadded infection, and you get emphysematous cholecystitis. So be careful for all the checklist, for all the items you have. Also here in the lung, you have some sort of infection. Okay. And you should look for the air, look for the fluid, look for the give contrast, and see, look for the coronal. You should mention all the important points, all the checklist, how you diagnose the case. They are not excited for the diagnosis. They don't they already know the diagnosis. They will not ask you about the diagnosis, but they need to hear from you how you go through the cases, how you make your reports. Please put this important issue in front of your eyes in all the cases. You must show your approach. And don't forget to have a general look for all the cuts from the first to the last cut before speaking or before describing anything, to start by the most important thing first. For this case, yeah, it was very good from him that there is silhouetting of the right heart border, and this is the right hemidiaphragm is preserved, so this is only right middle lobe. Here you can mention that there is middle lobe collapse or consolidation, but the lingula only consolidation, because the lingula will not collapse alone. And I think this was the first case. Yeah, please, 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 the emergency cases, don't fail in emergency case. You will ruin all the session, all the VIVA session. A 30 minutes VIVA session will end up losing the marks and failing it because of one case only. So if you if you have an important finding, describe it very well, and describe the whole process, what is going on, what the exact sites affected by this finding. So you mentioned that there is lateral ventricular dilatation, but you stopped there. Is it acute or chronic? So you started searching for the permeation and you got it. So why you must do it on your own from the beginning? You are losing marks without any gain from that. And if you find abnormality in the ventricular system, so you should go through the whole ventricles, the fourth, the third, the basal cisterna, the lateral ventricle, all the CSF spaces, you must comment on it. And then we conclude that the third and the lateral ventricles are dilated. So it is obstructive hydrocephalus. So please search for the causes. What could be this in the third ventricle here, causing obstruction of the supratentorial ventricular system? It is very, very, very important and very common. And failing to diagnose this abnormality will end up by the patient have global cerebral ischemia. It will end up by brain herniation. It will end up by multiple infarctions. Even the patient is still young, in his 20s, you ended his life. So this is not an easy mistake. It is not a forgivable mistake. This is a fatal mistake. So this is a colloid cyst. Please, the emergencies are very, very important, very fatal. Please take care of these mistakes. Overall, you are very good. You are very smart. You have much more experience than the British candidates, even. Most of you have previous certificates, previous exams, have done previous exams in radiology. So you already have the knowledge, but you must use this knowledge, and you must show yourself. You must present yourself, how you are thinking, how you are describing, how you are reaching the diagnosis. And don't they are not interested in the diagnosis. They are interested on how to diagnose, how to manage, and you must mention everything in details. I hope you enjoyed the session. Sorry for anyone get bored or feel sad from my
No,
pressure on
no,
him, but it must go like that. And
no,
yeah, the gold clue for this exam is training, training, training. Thank
no,
you,
no,
really.
no. Dr. Mahmoud, I must say the moment you started speaking, every statement was a golden tip to the candidates. I must say it.
Yeah.
And thank you so, so much for your time. I request humbly to be with us again as you are comfortable, as you are available. I am there with you. You know my number, email, everything. Just text me, and we are more than happy to have you again.
Yeah, inshallah, I hope I can.
No, it's a
Because
sincere request. I can tell you, every candidate has the same feeling. Every
thanks a
statement
lot,
you
really.
said was a golden tip. I can tell you, it was such an amazing review session, and
Yeah,
thank you so
thanks a
much.
lot.
And
Thanks a lot.
please be there with us again.
I
Diagnosis
hope
of
so.
last case was it was
A
a colloid
colloid
cyst,
cyst. Yeah, it was a
and
colloid cyst.
somebody's asking it first. So it was
Yeah.
it was a colloid cyst in the
Yeah.
third ventricle causing hydrocephalus with the emergency
Yeah.
treatment of acute hydrocephalus.
Yeah.
So we won't take much of your time, Dr. Mahmoud.
Yeah, thanks
Please
a
be
lot
with
for
us again.
all of you. Thanks a lot of having
Thank you
me
so
with
much.
you. It was a great honor.
No,
Thanks a lot.
it was the honor is with us. The honor is with us. I can
Thank
tell
you,
you.
really. Thank you.
Please be with us again. Thank you very,
I
very
hope so.
much.
Thank you. See you all again.
See you all. Bye. Have a
Yeah.
good night.
Bye.
Thank
Bye.
you. Bye. Bye.